Hello, my name is Terica Kelly. I am an 8th semester nursing student. Today is August 29th, 2018, and it is approximately 11:35, and today I'll be expanding on chest tube drainage and care. So to start off, I will go check my physician's orders, go into the patient's room, introduce myself, check my 2 patient identifiers, and then I'll begin to explain. So basically, if a patient is getting a chest tube, they typically have experienced crepitus, a pneumothorax, hemothorax, empyema, pleural effusion, things like that. So once all of that is understood, I will go on to assess the patient's heart rate, respiratory rate, their basic vitals, as well as how they feel laying in the bed, their position, and etc. I will then assess the tube site with gloves on. For the drainage, right here it seems saturated, so I would typically change it, but for the video I would not. And I would also document whatever I assessed. And then I would go on to assess the tubing to make sure there are no kinks, no like openings or anything like that in the tubing. So basically, this is the PLEUR-EVAC, and this is what the chest tube drains into. So there's a chamber for normal saline, which is the water chamber, and it's typically lined up to 2 centimeters, and when it's flowing properly, it should wave, the water should wave like the waves in the ocean, but when it's not, it will start bubbling. And when that happens, you should check the tubing, the dressing. It could be a hole somewhere or something's just not going right, and you need to assess and take care of it. And there's a chamber for suctioning, and typically that is the doctor's, per doctor's orders, but if you have a doctor's order, you could adjust it, but you should just leave it up to the physician. And for this side, it is the collection chamber. So that is basically whatever is draining out. So when it's your shift, you should label and mark it and make sure you document it in your charting. And when you have to change these, it's typically a two-person job, because you don't ever throw these away. You just put them in the biohazard container. So one person will be holding the tubing and making sure the patient is okay, while the other is trying to attach the new PLEUR-EVAC to it. So that is how that works. And after everything has been assessed and checked, I would just document everything that I've done and make sure my patient is in a safe, low position, provide privacy continuously if they want to, and